Okay, so I think we can go ahead and start. I hope everyone can see my presentation okay. If there's any questions, I'll just answer them at the end. So contraception is a bit of a big topic. We see it a lot in primary care. Now, generally speaking, we don't really deal with it, like initiating contraception and all that. We don't deal with it much as GPs. But again, it depends on your practice. Normally, nurses are the ones that initiate contraception, and they're the ones that give contraception. But you kind of deal with this stuff like when patients are switching contraception and things like that. But generally, nurses are the ones that really do the initial talk. But sometimes some patients would like to see the GP. So it's not something that you're not going to see. You're going to see more than you would like, honestly. Um, so basically, there's a few types of contraception out there. Now, what you're going to pick highly depends on the patient's preference, but also it depends on the risk versus the benefits. Now, we have the intrauterine contraception. I'm sure you're all aware of it, the copper, and then the hormonal one, which most commonly we use is the Mirena coil. We have the combined hormonal contraception. Now, the combined comes in different forms, like it comes as patches, it comes as rings, and it comes as the oral pills. Now, the rings, we don't use it as much, but the patches and the pills are the most common ones that we use. And then we have the progesterone only. And again, they come in a pill form, they come in the implant and the injections. Now, as I've said previously, choosing your contraception is really going to depend on the risk versus the benefits. I'm sure you've all heard about the UK MEC, which is basically assessing if the patient is okay to start contraceptions or not. Now, as long as they're categorized in the category one or two, then it's safe to give the contraception. But if they go under three or four, that's when you don't really give them, or you see if the benefit outweighs the risk. Now, for category three, the risks are higher than the benefits. So I would say please do not prescribe the contraception. And this is, for example, smoking, people who are overweight, any cardiovascular risk, uncontrolled hypertension, migraines, any breast disease. So all patients that go under this category, you would rather not give the oral contraception. Now, the intrauterine one is a different story, but this is mainly on the combined contraceptive pills. Now, the Ikimec 4 is actually an absolute contraindication, so we don't give contraception for these patients. When you're talking about the combined hormonal, of course, postpartum, we don't really like to give contraception at the beginning, but then we can give it later on. If they're heavy smokers and they've been smoking for a very long time, we don't really give contraception. Any uncontrolled high blood pressure, any current vascular disease, any history of VTEs, migraine with aura, current breast cancer, all of these are absolute contraindications, so you don't give the combined contraceptive pills with them. Now, current breast cancer is also a contraindication to the progesterone only. Um, so we really don't like to give it when patients have breast cancer. Now, speaking about the progesterone only pills, we don't really give it as well when there is vascular disease. So it's the same as the combined. So any vascular disease, we don't give it. Any unexplained vaginal bleeding, we don't like to give the progesterone. And that's because the progesterone actually causes unexplained vaginal bleeding. So if you're going to give progesterone on top of that, you're going to really, it's going to mask your judgment. So again, the risk outweighs the benefit. And of course, any previous breast cancer, even if it's treated, is highly risky. When you're talking about the intrauterine contraception, any current infections is a contraindication. Any malignancy is a contraindication, and any endometrial cancer is a contraindication. And again, do not prescribe contraception when there's unexplained vaginal bleeding unless you know what the reason is. Okay, so these are all the UK MECs, and you're going to go through them with the patient. The big ones really are the cardiovascular risk, uncontrolled hypertension, migraine with aura, and breast cancer. These are the big ones that you don't want to miss, and you don't want to be giving contraception or initiating contraception when a patient falls under these categories. Now, the choice of contraception, first of all, it really depends on the patient. But if we're talking from a medical point of view and the cost effect, then the long-acting ones are the ones that we prefer to try and, sell them to the patients. So basically, the IUDs or the PRPs, and PRPs, which are the implants or the injections, so they last from 3 months to 3 years, depending on which one you're gonna pick. And then the IEDs, and of course, these ones they last for years, like 5, 6 years plus. Again, depends on the type that you're using. Now, the pills, we have the combined and the progesterone only, as we said before. We like to prescribe the combined in the generic, the brand name. The PUPs, you can prescribe it whatever way you want. But generally, in a GP setting, we usually prescribe the combined in the brand name. Now, starting contraception is an important thing, and usually for the pills in general, we like to start it in the first 5 days because there's no further protection that you're going to give in the first 5 days of the cycle. If you're going to give it more in afterwards, after the 5 days, then that's fine. You can still initiate it, but they have to be protected for 7 days if they're starting on the combined, and for 2 days if they're starting on the progesterone only. Now, a lot of times women are not going to be able to tell uh, what day exactly they're on. So that's okay. You can start at any time and just assume they've passed the 6 days and just ask for them to take further protection. And of course, in this case, further protection we're talking about is condoms, basically, or, abstaining from sexual intercourse until the contraception kicks in. Now, there are the non-oral forms. We don't prescribe them very much in a GP setting, especially the rings. We don't really prescribe them, but the patches we do. And the main reason why we prescribe the patches is patient's preference. That's mainly the main reason. Now, there are some studies that are saying that the VTE risk in the transdermal one is lower than the combined oral one, but there isn't much evidence. So the evidence is very limited in these studies. Now, when we're coming to HRT, it is true. The HRT patches risk is much lower than the oral ones, but in the contraception, there isn't much evidence about it. So you're going to see patients coming in wanting the patches because they've heard that there's a lower risk. Now, just tell them that the evidence up till now is limited. But if they want to go ahead and do the transdermal one, it's fine. The ones that we prescribe is called Evra. And basically what they do is they put one patch on day one, and then they change it on day 8, and then on day 15. So basically once a week. Um, it works better if patients are not really compliant. So if they were on the pills and they want something that they can really stick to more. So putting a patch once a week is not a big deal. So that's when you can offer the transdermal ones. Now the rings, mainly the nurses are the ones that put them in. And we have the CERN ring and we have the NIVA, so we prefer the CERN ones. I think it's more just cost effect. There's no reason for preference apart from that. And again, we insert it on day one and then we insert it for 21 days and we remove it and we give them the 7 days. So basically, the rings they stay there for the whole time that they need coverage. And you remove it for the 7 day break and then you reinsert it again. But again, as I said, it's not very common. It's not something that we commonly prescribe or even offer, but it depends on the patient's preference. Now, an important thing to know with contraception is their side effects. People are going to ask you about the side effects, and it's very important in a GP setting to document because sometimes you're going to tell the patients about the side effects and they're going to deny that you told them about the side effects, and then they're going to come complaining that they want to change the contraception. So, any conversation in general in the NHS, as I've said in previous seminars, documentation is key. Now, when we're talking about the side effects, we just talk about them in general if you're gonna give them the combined one. So acne, irregular bleeding, breast pain, nausea, vomiting, migraines, All these are the side effects of the contraceptive pills. If you're going to give the progesterone only, the main side effect from the progesterone only is irregular bleeding. Now, some people don't prefer to go on the progesterone only for religious reasons. Some people prefer the progesterone only because it stops menstruation in some patients. So in some patients, they would get these irregular spotting, but if it's someone that has like heavy bleeding, progesterone only is one of the things that we actually offer in a GP setting. So let's say you have a patient who's coming in with menorrhagia, and she also wants a contraceptive for like a contraception. We normally tell them to go with the Mirena. If they don't want to get the Mirena, they don't want to get coils in them, then you offer a progesterone only pill. So these are the main side effects. Now, another side effect that's very common for contraception is mood swings and weight gain. And these are two things that women don't really like to get. But you have to be honest, you have to tell them about the side effects and they can, take the decision on their own. Now, if you're going to put the IUDs in, one of the common side effects is the risk of ectopic pregnancy. Pain is one of the things that can happen. Now, especially with the copper, if you're putting the copper IUD, increased pain and heavy menstruation is one of the side effects. So if they're happy and they're aware and they want to put it in, then we can go ahead and sort it out for them. Now, IUDs insertion are sometimes done in a GP practice, but in other times you can just refer them to the family planning clinic. So it depends if you have the service in your practice, then you can go ahead and book them in. But if you don't, then just tell them to call the family planning. Now, switching contraception is important. And sometimes what happens is a patient comes in, they're on a certain tablet or a certain form of contraception. They don't like it for whatever reason, for the side effects, for example, and they want to switch to another form. Now, cross-tapering and being able to tell if they need protection or not is important because if you switch contraception and a patient get pregnant, you're the one who's going to be blamed. So basically, how we do it is that we go with the weeks and types. Now, if we're doing the combined contraceptive pills and we're doing it in week 1, if we're switching to another combined contraceptive pill, then they need to have protection for 7 days. If you're going to swap from a combined contraceptive pill to a progesterone only, then you're going to only have cover for 2 days. Okay. Now, if you're going to go ahead and do the IUDs, now if you're going to do the hormonal one, again, they're going to need protection for 7 days. If you're going to do the copper one, they don't need protection at all. And if you're going to do an implant, they're going to need contraception for 7 days. Now, this is a lot to memorize, and technically speaking, it takes practice and experience for you to know how switching contraception works. So I would say it's not shameful and it's definitely okay for you to tell the patient, I don't know, I'm gonna check and just check the guidelines on your computer for a few seconds. It's better than saying something that's not true and then the patient gets pregnant, okay? So going back to the weeks, um, now if they're on week 2, week 3, then normally they're covered. We don't need any further protection, and we just swap them over. Um, that's for most of the contraception, apart from the Marina. We usually try and give them like 2 to 3 days instead of going ahead and, telling them that they're completely protected. Now, this is for the combined contraceptive pills. If we're gonna switch them over from a progesterone only, then there are different rules that apply. If you're going to switch from a progesterone only to a progesterone only, you can do it at any time. There's no further protection needed. If you're going to switch from progesterone only to a combined, if we're talking about day 1 or 2, you don't need any protection, but any further, you're going to need protection for about 2 days. If they're from 3 days to 7 days, okay? If they're on week 2, week 3, you don't need any further protection. You can switch from a progesterone to a combined on week 2, week 3. Now, what we normally do, to be honest with you, in order to make things easier for ourselves, is that we switch patients over in week 2, week 3, because most of the time, most of the rules in week 2, week 3, we don't need any further protection. So we just tell the patient to wait a bit, and continue for a few days, and as soon as they hit 2 to 3 weeks, we can swap them over easily. This is general advice. Some patients, they don't want to wait further because the side effects are not tolerated, so you can go ahead and swap them. But if the patient is okay, you can tell them this plan instead. Now, when we're switching from an IUD to a combined
When
contraceptive,
when is it?
basically up to day 5 of the menstrual cycle, we don't need any protection. But any other time in the menstrual cycle, we're gonna need 7-day protection. That's if you're removing an IUD and giving them the tablets. Okay, I hope this is clear. I know it's confusing and it's a lot of information. Now, I'll send you the links to all this, and you're gonna find easy like algorithms and tables and things like that. So if you want to print it out or keep it in your computer, if you're doing any consultation in contraception. But as I said, with time, it's gonna be very easy for you to memorize it. Now, apart from switching contraception, missed pills is a big one. Now, with missed pills, what we normally do is as soon as we finish the consultation with patients with contraception, we just send them a link for the missed pills rules. Because honestly, it's not so easy to memorize. That's first thing. And the second thing, people miss their pills a lot. And it's gonna be a wasted consultation for them to call you to ask you what to do when they miss a pill. So what we normally do in most of the practices they do is they send them a link with all these information. Side effects and missed pills are the main ones that we send over to the patients. Um, if we're talking about your exams, you're gonna need to memorize this for your AKT and for your SCA. You're gonna be asked about them. So generally speaking, we divide it into weeks. So if we're talking about the combined contraceptive pills, if we're doing it, if they're missing anything in week 1, if they're missing only one tablet, the same rule applies. One tablet anytime, just take the next tablet ASAP, and that's it. Okay. But if they're missing more than one tablet, so 2 to 7 tablets, you're going to need to consider emergency contraception if it's the first week. Okay. They're going to take the next pill ASAP anytime, even if it means that they're going to take more than two tablets at the same time. Now, generally speaking, if they're missing 2 or more pills, then they're going to need to avoid sexual intercourse or use a barrier method until they've taken 7 consecutive pills. Okay. If they're missing 2 or more tablets in week 2 to week 3, they don't need to take emergency contraception, but they're going to still need to use barrier until 7 consecutive days have been all taken. Okay. When you're coming to week 3, and they've missed more than 2 tablets, they're gonna have to omit the hormone-free interval. So the 7 free days, they're gonna have to omit it, and they're just gonna take what we call back-to-back. This is for the combined contraceptive pills. Now, for the progesterone only, it's a bit easier, because basically, if they're missing one tablet, we really divide it into hours. So if they're missing anything, the pill is considered late. If it's after 3 to 27 hours, then the length of precaution is normally 2 days. And that's why the progesterone is a bit easier because we're only talking about 2-day protection, 2-day, extra precaution and so on. Now, need for emergency contraception with the progesterone only tablet. If the pill has been taken absolutely fine, for at least 48 hours, then we don't need emergency contraception. This is the general rule. Unless they've missed it more than, 12 hours or more than 3 hours, then they might need emergency contraception. Um, and they're going to need protection as well. Now, contraception in women above 40 is another topic. The general thing is when women are around their 40, they might have started HRT as well, or they might need to start HRT. So generally speaking, HRT is not a contraception. And you have to tell them that because a lot of women don't know and they assume if they're taking any kind of hormone, they don't need to take contraception. So some women would be on a contraception pill, for example, and they stop it because they're taking the HRT. Okay. So what we normally do, we require contraception for women above 40 up to the age of 55, especially if they don't know if their periods have been when they've stopped. So some people, because they're on a specific kind of contraception or their menstrual cycle has changed, they are not able to tell if they've gone through the menopause or not. We don't normally offer bloods in order to check for menopause, so that's another thing to keep in mind. And we're going to talk about it a bit further in our HRT seminar. But generally speaking, a lot of women would come in asking you for bloods for menopause. It's a clinical diagnosis, and especially if they're on contraception, it's not where you're not going to be able to interpret it. Now, most of the progesterone only methods are the ones that we prefer with women above the age of 40, especially if they're going to option for HRT, because you can give them the Mirena and then you can give them the HRT on top of it, and it's, two things in one. So basically, they will be covered with the Mirena for 5 years if they're doing it if they're doing it for HRT. Now, the combined contraceptive pills are still licensed for women below the age of 50, but it's not an alternative for HRT. So you can give them and you can give the microganon as a first choice for any women above the age of 40. But keep in mind that the most important thing is that their VTE risk is low and they don't have any risks. Like, for example, they don't have a high UTI, sorry, a high risk of VTE, a high BMI. They don't have uncontrolled hypertension because when they're approaching the age of 40, 50, they're going to have a bit of comorbidities and a bit of past medical history. So you need to keep that in mind a bit more than giving contraception for a 16 or a 20-year-old women. So generally speaking, we prefer the progesterone. But if they option for the combined, it's fine to use it up to the age of 50. Okay. But when they hit the age of 50, we usually stop the combined contraceptive pills and then we try to give them something else. Is that clear so far? Now, that's it for contraception. If you have any other questions, I'm happy to answer them in our next seminar. I'm going to cover emergency contraception because it's an important one. And we do get a lot of, consultations about it. And if it's not consultations, if you're doing like a message board in your GP setting, you're going to get emergency contraception questions and HRT and gynecological cases. So that's it really for me. I hope that was okay for you.